Welcome back. We often talk about a doctor shortage in Canada, but it seems we have more doctors than ever. Some new research points to different issues in healthcare. Here's a look by the numbers. First, the good news. Canada has plenty of doctors by historical standards, 247 physicians per 100,000 Canadians. That's 124 family doctors per 100,000 people. Compare that to 116 in 2015 and just 73 in 1976 at the dawn of universal health care. And yet more Canadians, 6.5 million by one recent count, say they don't have access to a family doctor. Research from Get Well Canada suggests spending to prevent illness may be a better solution. Back in 1976, provinces spent more on education and social investments than on health, as much as 55% more in Newfoundland and 22% more in BC, 16% more in Ontario. Compare that to today. Newfoundland spends half of what it spends on healthcare, on social or education investments. In BC, the gap is 2/3, and even Ontario spends 5% less. And yet, new spending on healthcare, including $200 billion promised by the federal government over the next 10 years for healthcare, will be focused on the point of care, not on prevention. In the past 4 decades, the feds have picked up the slack on social and education spending, though. They spent 43% more in BC, 7% more in Ontario, and 73% more in Newfoundland. Meanwhile, our healthcare bill keeps rising. Total health spending in Canada hit $344 billion last year. That's equal to 12.1% of our country's GDP. Well, spending more in ways that aren't working doesn't seem like the best plan, so why not refocus our spending on places that help prevent illness and disease? Paul Kershaw is one of the authors of this report and a founder of Generation Squeeze. Great to have you with us, Paul.
Thanks so much for having me. And I almost feel like I'm redundant. You gave such a good summary of the report. I can just sign off right now and say, you keep talking.
It seems as though historically we kind of got the joke that if you spent on social investments, on things like education, on preventative medicine, it actually prevented people from needing that point of care service. Why have we lost the plot? And why do we keep spending money in a way that actually isn't the most effective way?
Well, I think there are a couple of factors. One's cultural and one is sheer politics and lobbying. So on the cultural side, I think in the Canadian context, we find it difficult to know what it means to be Canadian, but we can say we're not our neighbors to the south because we have publicly funded medical care. And that then gives rise to this cultural reaction that says, hey, if we want to be more just or more Canadian, let's do more medical care, even though the health science tells us that's not the way to make us healthy and well, and that's not the way to reduce burnout amongst medical professionals who are just saying there's too long a line of patients. That's the first factor. The second factor, and I say this with a great deal of esteem for my physician colleagues, I'm in the Faculty of Medicine at UBC, but as great as our doctors groups are at championing health and medical care for their patients, they are also a really powerful lobby in Canada. And sometimes that lobbying takes forms that helps to accelerate the revenue we use from tax dollars to pay their remuneration. And we need to find the right balance between making sure that we continue to retain and attract enough physicians, but also invest in the things that the physicians desperately want to. Like, they wish they could prescribe childcare. They wish they could prescribe affordable housing, a stable environment, poverty reduction. That's what would take the load off them in terms of the long line of patients. That's not the job of doctors. That's the job of governments. You, in the report, note that even this government has said you measure what you're going to focus on. What are your recommendations here in this report to help try to change how we just throw money indiscriminately at one part of the system? Brilliant question. So at the federal level, at every provincial government level, and also for the Canadian Institute of Health Information, all of these groups do reporting on an annual basis, and they need to start measuring the ratio of how much money are we putting into the building blocks for a healthy society, think childcare, housing, education, poverty reduction, relative to treating illness after people fall sick or injured. It's a simple ratio. The health science says grow the building blocks even faster than medical care. Right now, the provincial and federal governments don't monitor that. And the Canadian Institute for Health Information is letting us down on that front. They are the national institute to monitor data relevant to health, not just medical care, but CIHI is their acronym. And CIHI gives us tons of data about spending on physicians, on pharmaceuticals, on medical care in its entirety. And they give us very little, almost next to nothing about the building blocks for a healthy society. And so they skew our attention away from what actually makes people well and keeps them out of our clinics and emergency rooms.
We've only got a few seconds, but I want to hit, Generation Squeeze looks at the imbalances between demographic groups. Healthcare, the way we're doing it, does favor the elderly. We tend to use, of course, the most expensive parts of the system right before we die. Is this a generational imbalance as well? We're spending on old people and we're kind of shortchanging younger people.
It is absolutely the case that, we're talking about my mom right now. I want her to have a healthy retirement, but we use more medical care after age 65 than we do in our first 6.5 decades. And when we only spend on illness treatment, or we disproportionately spend on illness treatment, we crowd out investing in the things that keep our kids and grandchildren well. That's not really the legacy that many of our baby boomer parents want to be leaving behind.
Paul, it's great research. We really appreciate your time today.
My pleasure. Have a great day.
Paul Kershaw is founder of Generation Squeeze. Well, Paul mentioned some of them, but what are the most effective ways to improve healthcare outcomes, spending on social well-being? Daniel Dutton is an assistant prof in community health and epidemiology at Dalhousie University. Daniel, you've looked at some of these things, and we did just hear them, right? Things like poverty reduction, child care. When you look at sort of the preventative arm of spending, what comes to mind as things that would keep us out of the healthcare system?
Well, the good news is it's stuff we already spend money on. So when we look at the things that work, the things that have the highest return on investment, if we use that language, it's things like income support, support for housing supplements, and what we call boring programs, because they already exist. There's no innovation that needs to happen. But as Dr. Kershaw was talking about, and as you mentioned earlier, the funding for these things hasn't been growing to keep pace with other things that we spend money on, and there is a tension between how we keep people healthy and what we spend money on. You see it rhetorically whenever there's an election. We talk about the health of Canadians. We always tie that discussion to the healthcare system rather than spending on the things that truly keep people well.
It seems, just at a guess here, that poverty reduction would be one place where you would actually make some big changes in terms of access to care, including the most expensive. We talk about emergency rooms replacing the point of care for a whole cohort of our population. Would that be a place to really focus? And I know this government has done that, certainly with the child benefit. Could we do more on that front that would keep people out of emergency rooms and in better health?
Yeah, certainly affordability is something that you hear in the news all the time with respect to food prices, housing prices, etc. And there are two ways we can act upon incomes so that people are able to meet these higher budgets, or we can act on suppressing the things that are driving costs, which disproportionately affect the worst off. And those people who are being disproportionately affected are also the people who typically have a harder time accessing primary care and end up accessing, as you say, the expensive emergency care. And the discussion around that always turns to the appropriateness of this care seeking. I don't think that's a helpful language, because what I think is actually happening is these people are being driven by a true need that is based on the environment within which they live their life. And so food insecurity is a topic that comes up all the time. The most food insecure households are typically the households that end up consuming the most health care. And we can very easily act to fix food insecurity. But it's not obvious that the action on food insecurity is action on things that improve household budgets rather than things like food banks or food delivery. So really, it's about addressing these structural environmental factors rather than trying to pinpoint all the little items that are driving the costs. And I don't know if healthcare spending is truly driven by cost rather than driven by norms of growth and expectations of how we assign those dollars year after year.
That's really an interesting point, right? And a problematic one, we can imagine. I'm curious, we don't have a ton of time, but when you hear sort of the research that Paul has done and all the work that you've done, are you optimistic at a shift in thinking around reallocation of budgets, knowing that budgets aren't endless and that we don't have vast resources forever and ever? Could we do better? And are you optimistic that we might?
I'm optimistic that we might, because I think what Dr. Kershaw advocates for is the measuring of the social to medical spending ratio, which I think is a helpful tool for governments in making decisions and guiding how we talk about this problem by bringing on social spending as an explicit consideration of population health. I think that people see themselves as users of the healthcare system. They might not necessarily see themselves as users of the social care system, but talking about how they're potentially beneficiaries of a more enriched social care system is a helpful way to have that discussion.
Daniel, so good to have you with us. Appreciate your time today.
Thanks for having me.
Daniel Dutton is an assistant prof in community health and epidemiology at Dalhousie University. Coming up, are gig workers being exploited? We'll take a closer look. But first, Air Canada learned the hard way the limits of artificial intelligence. That came after a chatbot on its website offered inaccurate information about a bereavement refund policy. In a case brought by a customer, a tribunal was told Air Canada viewed the chatbot as responsible for its own mistake, not the company. The tribunal agreed to disagree, but I guess you can't blame the airline for taking a flyer. We're back after this.